If you take a seat up here. So these very interesting papers now open for discussion. Any questions? Anybody want to ask a specific question?
In the last slide, the studies that you mentioned where patients had coronary artery surgery based on FFR-guided lesions versus angiographically evident lesions, did the number of grafts change? So were there patients who would otherwise have who would have otherwise have had grafts if you just based your decision on angiography? Did the number of grafts go up or go down in the FFR group?
I showed this to you in the previous slide. There were less grafts. These patients had much less graft, particularly have much less multiple grafts.
So patients who had less grafts did better than the patients who had more grafts?
Yes. I mean, or the grafts probably to the non-relevant lesions they occluded premature or early. That's probably the result. There was not an outcome study. It shows only the patency of the grafts. So,
thanks. Any other question at the
back? I just wonder if you reclassify a patient from a free vessel disease patient to a two vessel disease patient based on FFR, and you perform PCI instead of surgery. Is that any evidence for such an approach?
No, I don't think this is the right conclusion, because our decision to perform PCI or CABG at the moment is based on the anatomic results. So we should not change this. We may have to consider this for the future, of course, if you reclassify the patient. But the first would receive the angiogram, and that should make the decision PCI or CABG. And then in the next stage, we should really reconsider how many of these vessels to treat, or maybe not to treat any of these vessels. You know, some patients had even no significant lesions according to FFR.
Thanks.
I agree, but I see this coming now.
There's a question here.
The results of the FAME2 trial showed there was no benefit in terms of hard endpoints, if you count MI and death as the hard endpoints, with an FFR guided strategy. Do you think we're being a bit too quick to take on this new technology? The only difference was in the need for revascularization, and no difference in MI or death.
It's always me I'm talking here.
Sorry.
Philip, you're from the home of FFR.
Yeah. I think that FFR is, as I said, quite important. And if you have a lesion that you think was significant and is not, I think it can modify the strategy, whether for PCI or for CABG, in my opinion. I don't know. Was it your question?
No.
It just seems that FFR has gained kind of great prominence as a technique, but by doing an FFR, you don't establish any difference in MI and no difference in death. In the FAME2 trial, there was no difference. So, are we putting too much importance on this as a technique?
I see what you mean. Well, because it's only on repeat revascularization. It's a good point. What I can say is that because of the difference, I mean, the safety board decided to stop the trial prematurely after 54% of patients included. So I would guess no, that we are not putting too much emphasis.
If I could make a comment on that, actually, FAME2 was worse, even worse than what you've suggested for a number of reasons. Not only was there no difference in the hard endpoints of death or MI, but the trial was ended because of the patients who required urgent repeat revascularization. And that was decided on clinical grounds by interventional cardiologists who knew how the patient had already been treated. So the end point of this was totally unblinded. If you then look at the fact that the chairman of the steering committee is an interventional cardiologist, you can read into that what the potential conflict of interest is in having a trial like that. So the FAME2 trial was very heavily criticized in the New England Journal of Medicine in the correspondence when the trial was ended, because it was ended on an open ended, so it wasn't a blinded endpoint in which it was finished. So it was open to all kinds of manipulation and distortions. Because if you wanted to be very cynical about this, if you believe that interventional cardiologists have a wish to do interventional cardiology, they therefore have a wish to demonstrate the advantage of PCI or its importance. And therefore, you could, had the chairman of the committee not been an interventional cardiologist.
But Bernard Gersh was among them, and he's not an interventional cardiologist, David.
No,
so
sure. But what I'm asking is, should the chairman of this trial have been an interventional cardiologist? It's just another viewpoint. I'm not saying it's right or wrong.
Thanks very much. Any other questions? The back here.
In cases where we have FFR readings and the patient is planned for coronary revascularization by surgery, what do we do with vessels that have borderline FFR values? For example, 0.8 to 0.9. Do we not revascularize those, knowing that in a year or so they may need revascularization? So if we're basing our decision to revascularize on FFR, what do we do with those borderline values?
Well, the answer from the trial is that the cutoff value is 0.8. If you're above 0.8, then you perform an anatomically driven revascularization where you increase the risk as compared to FFR-guided treatment if you go to the trial. So you can say, I don't... But you,
what happened to those borderline FFR values at 1 year, 2 year, 3 year?
I don't know what Chris thinks, but you mentioned borderline, but there were no three. There wasn't a borderline group in the trial. There is not below 80, then between 0.8 and 0.9, and then above 0.9. That's everything above 0.0. They are included in the registry if you look FAME2, and these patients do well on OMT. That's all what you can say. You could do a further study and then compare 0.8 to 0.85 and then something higher. My suspicion is that there is a tendency, and probably more in the PCI group than in the CABG group, to overtreat lesions just because they are seen on the angio. And you don't know whether a lesion, like you say, is borderline and the patient has never have had optimal medical treatment before because he didn't know he was sick. And now he's receiving statins, beta-blocking agents, aspirin, numerous other treatment. Maybe his lesion will stop and even regress. That happens, if I want to be provocative.
A normal FFR has an excellent prognostic value. I mean, that's what the lessons we have to learn. So the likelihood that this lesion will progress seems to be very low. But this, and the reason for at least performing PCI in this lesion is higher than just leave it alone. We don't know whether this is true for surgery. What we have just learned from this one study is that probably your grafts will occlude. If you graft a lesion that has a normal FFR, you have a higher likelihood that graft will occlude. But we don't know how this will end up in long term. That's maybe 10 or 20 years. That may be different if the graft stays patent. Of course, that's the prerequisite.
There's a question in the middle here.
Hi, hello. My question will be a little bit different. Do you think, in the larger perspective, is it any role of surgery in the acute settings in terms of STEMI and non-STEMI, especially when we see that incomplete revascularization can impair the long-term results? And for example, you come with a patient with a STEMI and the cardiologists know already they can't do the proper job from the very beginning. Do you still think there is a role for surgery in acute settings, which almost not seen at the moment? Thank you.
I mean, the current evidence suggests complete revascularization gives you the best results prognostically and as well as early mortality rates. So if one considers with today's presentations that within 5 days or within the guidelines of 3 days, then ideally you should do a complete revascularization. If it were to be a culprit lesion, intervention by PCI, then one would argue that you may still have to take them back to theatre within the 5-day period and completely revascularize the rest of the segments.
But STEMIs should go immediately to the operating room, in most cases that's probably cannot be done. But at least in my place, for example, about 4% of all STEMIs go directly to the surgeon.
Yeah,
that's
that's
a
what I
critical
was
main stem lesion or whatever, and
most institutions
if you have surgery on site,
almost abandoned the interventions with the acute myocardial infarctions. It's very rarely anyway.
Yeah,
unless it's.
But the outcome, I think, is not so bad. If you have surgery on site, it should be done without delay, should be done immediately, and of course that's not given at all places. But if you have it available and the surgeon is ready to go immediately without delay, directly from the cath lab to the operating room in these places, it can be very helpful for the patient. And at least in my place, it's about 4% of all STEMIs go directly to the operating room. Could I have a show of hands from the practicing cardiac surgeons, any that would take an acute MI straight from angiography to surgery? So anybody would do that? 1, 2, 3, 4. So in some respects, surgery has handed this all back to interventional cardiologists. Could I take a second show of hands? What do you think? What do we as surgeons think our role is in the acute coronary syndrome? Because also, it seems to me we've handed that across to acute cardiologists. Do we think we have a role in the 3-day to 5-day window after presentation with acute coronary syndrome? Does anybody believe we have a role? Thanks. Now, the reality of that is that we don't. You know, we may think that, but many units, interventional cardiologists, we may have MDTs doing lots and lots of stuff to do with elective patients or patients post 3 to 5 days. But it seems to me in the 3 to 5 day window we're not involved, and possibly there is a message for us in that. Does anybody like to comment on that?
Yeah, I'd comment on that. I think the scenario you described, Danny, 2 or 3 years ago would have definitely been the case. Most of our acute coronary syndromes would have just been dealt with by the interventional cardiologist with no discussion. But certainly in my centre, we've seen quite a marked transformation in that. And almost all acute coronary syndromes are now discussed by an MDT. The exception being obviously STEMIs. There's no discussion. They go straight to the cardiologist. But it is now in my centre very unusual for the cardiologist to stent, even acutely in acute coronary syndromes, with the specific situation. If they think that patient needs to be treated before the next MDT, they will then call the surgeon and discuss it. So in our centre, we are certainly seeing far more discussion of these patients than we did 2 or 3 years ago.
Thanks. Adrian. Sorry, Adrian. Hard one to miss.
Oh, thanks, Danny. Yeah, Danny, I disagree with you because, especially from the CRG work, taking down the time from an angiogram to a definitive revascularization must produce the fact that they're going to talk to us early. I know that it has in my institution and throughout the West Midlands. I think that's quite common as well. I agree with David there. I think that we are actually putting in place mechanisms which will make us far more joined up with actual the 3 to 5 day period than they were 3 years ago.
Yeah, I totally accept that. I think that's something we do need to bring in through the reference group. The bringing back of surgery into the acute coronary group, because there is no question we did hand it across to interventional cardiologists. So, colleague at the back.
Danny, excuse me, can I say this? We didn't hand it over. We had it taken away.
You get it back.
I was too polite to say that there.
This point of clarification.
Going back to the issue of functional assessment, if we're going to start changing our philosophy in revascularization on functional lesions, is FFR the best test for that?
Yeah. Could I actually add to that? We have essentially now 3 other tests. We've got echo, we've got nuclear, and we've got MR, and we've got FFR, which is different because you have to put a tube in. So how should we, somebody presents to us chest pain, like I think one of the colleagues mentioned pain, which is very, very good to hear because it all started off with pain in the chest, angiogram. So what's the next test that we should be doing in the patient with symptoms? And I think one colleague said maybe nothing, and the other without, well treated on medical therapy. Which of these different modalities should we be going for?
Chris, you want to address that first?
Of course, we like to have non-invasive ischemia tests before the patient has an indication for angiography. I mean, if that's to start out with. And the problem is that then the patient has triple vessel disease and maybe has a high-grade LED lesion. He has ischemia on the nuclear test or whatever you perform, or on the stress echo. And he has, two other lesions that are, between 60% in the right coronary artery and the circumflex, and you don't know what to do about it. And this will also escape your non-invasive stress testing, because they will always be limited by your high-grade lesions in the anterior wall. And for these indications, then you should teach or tell your cardiologist that you want, for the other lesions, evidence that this is also becomes ischemic at stress, and the only way to find this out is FFR. This will not be seen by any non-invasive tests.
So tell me this: you've somebody comes up, has stress testing, just as you say, has an angiogram, and is being discussed for surgery. And you would suggest to an invasive cardiologist to go and do an FFR and not do angioplasty?
Well, they should do the FFR when they do the angio. Yeah. I think that's one of the problem we have is that the patient are not, completely evaluated. And in a complete evaluation, in my view, what we need is clinical risk factors, being Euroscore 2 or STS or both, to know exactly where we stand. Now we know that some risk overestimate risk. That's another story, but at least we have that. Second, we need a syntax score. We know where we are. We can discuss like at the MDT, like David emphasized this morning. And three, we need the hemodynamic consequence of the lesion. We need an FFR, and then we have the functional importance of the lesion, because you can have a patient that has chest pain, has that particular clinical risk. You think it's a 2 or 3 vessel disease, but actually the LAD is not significant, so it goes down to a circ and a ride, or the other way around. Obviously, if the patient had the cath, you're not going to send him back to the cath to do the FFR if it was not done. But I think it's more institutional protocol that these patients should be managed A, B, C, D. Thanks very much. That's what I think.
I think the scenario Dr. Ham outlined is what's actually being done now. You have a significant, say, anterior lesion, and then you've got a intermediate lesion in the right, and you ask for FFR prior to taking them to surgery. But with FFR being done more on a routine basis now, you may get the cardiologist telling you you've got multi-vessel disease, but your only positive FFR is, say, the LAD and an OM. Those are the ones that need grafting. Should we take that with a pinch of salt and do another functional test? That's my question.
Okay.
No, the other functional tests, non-invasive, are then very limiting. So you have to do FFR. And in my places, we do about 20 to 30% of the cases with coronary artery disease. We already perform FFR, and you will experience surprises. Some cases, patients that you think that's a single vessel disease and the other lesions are not really relevant, you do FFR, and the other lesions, you find out that they're highly relevant. And and immediately this is a diabetic patient that has triple vessel disease, needs surgery instead of PCI of the one lesion. But it also may be the other way around, that it turns out that these 70% lesions has an absolutely normal FFR, and then it has a single vessel disease. But I see in both directions much more clearer information how to best treat the patient. And my surgeons even ask for FFR already. They say, okay, do you sure that this is a relevant lesion? and maybe it's only a single graft to the LED, and then we say, okay, no, needs FFR is abnormal, needs complete revascularization, all lesions.
You know, if you go back to physiology, that seems logical. FFR is a comparison between the pressure measured before the lesion and the pressure measured after the lesion on the maximal vasodilatation obtained with adenosine. Do I'm correct? That's one of the way to do it. So if this is normal, it means that what you see is not significant from a hemodynamic point of view.
Not necessarily, because if you've got multiple collateralization, if you've got consecutive lesions, so there are fallacies to the FFR as well.
Absolutely, sure.
Correct. Well, okay, you have hemodynamic lesion, but they are probably not ischemic then in the case you mentioned.
Two up here, please. Sorry, is the microphone... Okay, far away, and then we've got two here.
So I'd like to ask the two cardiologists who have spoken today about FFR and what they think about other conditions that are commonly seen in patients with multivascular disease, like a high hyperemic microvascular resistance, which we know creates false positives and false negatives with fractional flow reserve. And would it be correct to say that the widespread application of FFR, especially to cardiac surgery where it hasn't been properly evaluated, is premature?
Thanks. Do you want to shoot?
FFR is very nicely standardized, and it's, if you perform with adenosine, it's rather reliable test. But also, of course, it's only one piece for your decision making. It's not everything, you know, and it should be limited to lesions that are intermediate, and then it gives you some additional information in my daily practice, and you will be surprised to find sometimes.
So as many as 1/3 of FFR values below 0.8 will be artificially altered by a high microvascular resistance.
No, because adenosine is reducing the percent.
Okay, thanks.
So to come back to your question, I mean, as I said in my talk, we don't have strong evidence for CABG. We have a lot of evidence for PCI, FAME2, and other studies. We have some evidence, including this study published last year, which is also in favor of FFR-guided revascularization for CABG. Well, we don't have very strong evidence, so I can agree with you that we cannot give a 1A recommendation for that, for example. That would be premature.
But adenosine is the most potent peripheral vasodilator.
Yeah.
And so if the patient does not respond to adenosine, then...
Yeah. But on the other hand, I think that we have a tendency sometimes also to be ocular reflex and bypass lesions that probably should not be bypassed. That's my opinion.
Thanks.
If you allow me to comment from my surgical point of view to the whole FFR discussion, I think the FFR measurement is certainly a very valuable information. But if I interpret the FAME study, and you think very simply, it means that implanting in a stent in a lesion that is between 50 and 70%, or 50 and 80%, and has a FFR above 0.8, means that this lesion, the natural course of the disease of the lesion, is better than implanting a stent. So that means the stent makes a worse disease out of this lesion simply by plaque sealing. And yeah, I don't think that this is, you can translate that to bypass surgery. The success of bypass surgery has been over decades to graft every vessel that is 1.5 millimeters or larger and has a 50% diameter reduction. So I don't understand the temptation that is coming also from our cardiologists and ask me, why don't you want to follow the FFR guided strategy with your bypass surgery? And the answer is because the bypass surgery has been demonstrated to be very successful and to improve survival since years.
Absolutely, yeah.
And as a matter of fact, this plaque that has a 50% stenosis but the FFR of, let's say, 0.95, yeah, this plaque in the future, certainly it might not cause ischemia by gradual narrowing, but you might have plaque rupture and a complete thrombotic occlusion with a STEMI.
I completely agree with you. There's no evidence so far that there's any harm if you place a graft to a vessel with a normal FFR. What you have shown only was shown that the graft patency is lower in vessels that have a normal FFR, because quite a number of vessels probably will occlude. From cardiology point of view, I would say that you don't do anything wrong if you place a graft there, but you don't need to place a graft there. That's if you want to, go ahead, but it's maybe not really necessary.
Thanks very much. We're going to wrap up now with David.
Thank you. So if I can just make a comment about FFR, where I think it's useful in surgery is if you have a lesion, if you have a big vessel and it has a lesion on FFR of 0.81, you say, I won't graft it, whereas if it was 0.79, I would. And where FFR is useful is allowing you to decide where to place your grafts. So if I took a patient to theatre with a big vessel with a lesion, with an FFR of 0.8, I would graft it, but I would use a vein graft. If my vein graft goes down, as shown in syntax, it makes no difference. It's an asymptomatic graft closure. What I would use FFR for is to dictate where I'm going to put my two internal mammary arteries and my radial artery. Because by knowing the FFR, I can work out where these arterial grafts are most likely to survive. And I think that's the potential value of FFR.
Absolutely.